So are we starting or we have some time?
2 minutes, sir.
Okay.
I'll be having a one minute introduction.
No,
then I'll hand
please.
over the session to you.
Sure. Maybe let's see. Let's few of them have joined. Let's ask Jacob if people have joined. Then we'll go ahead.
Yeah.
Sir, we'll start sharp at 7. We have some time.
Yeah.
Okay.
Right. Already 27. So people will be joining. We can start at sharp 7. So recording has started, right? And that YouTube also, right?
Live streaming on YouTube as well.
Seven.
Good evening, Doctor. I, Chayan Majumdar, on behalf of JIDUS, welcome you in Masterclass Series 1. We're happy to organize this masterclass in association with Department of Gastroenterology and Hepatology, Kasturba Medical College, Manipal. At outset, I'd like to convey my thanks to Dr. Shiran Shetty, HOD and Professor, Department of Gastroenterology and Hepatology, Kasturba Medical College, Manipal, for conceptualizing this entire event and helping us to bring an expert who is going to discuss basics of gastrointestinal sonography. Let's welcome our speaker, Dr. Amit Pathak. Dr. Pathak is a senior consultant, radiologist, and ultrasonologist, Aryabhat Hospital, Meerut. There are numerous articles on radiology published in national and international journals to his credit. Moreover, he is an educationalist. He has delivered numerous educational talks on Indian history and co-authored with several books written on Indian history. We believe this masterclass will be useful in your day-to-day practice. During the masterclass, you can post your question in the chat box. Now I request our respected moderator, Dr. Shiran Shetty, to start today's masterclass. Over to you, sir.
Yeah, good evening, everyone. Thank you, Mr. Chayan, and thanks, Zydus, for giving this platform. It was a great pleasure to be part of this. And I think I would like, thank all of you who have joined and who have been worked for this meeting. So today, I think, as we discussed, it's going to be basic GI ultrasonography. In this era of therapeutic endoscopy and endoscopic ultrasound, it's very important that our postgraduates and the physicians who perform endoscopic ultrasound should have a fair, good knowledge about transabdominal ultrasonography. So me and Dr. Pathak actually had designed this, and it's going to be very basic so that, it's going to help or initiate interest among young colleagues, so that people can start doing ultrasonography, mainly the hepatobiliary, and once they start doing EUS, it's going to be more and more easy. And I think we have already introduced speaker. I think Dr. Amit Pathak is an alumni of KMC Manipal, and he is a great ultrasonographer. And people who don't know, he's from Meerut. Meerut is quite famous for our ERCP and EUS. So he is a man behind EUS there, and who has been initiated a lot of training programs for the young gastroenterologists. And he is also a good academician. And always whenever we ask him, he's always there. So I thought it's important, because during this difficult time, COVID, I think all of us are aware that we are passing through a very tough phase as a doctor or as a person or as an individual. So first, let us pray for all this, pray for good health, and then we start this academics, because we cannot stop academics, and we want our postgraduates and the physicians related to GI to learn and keep learning. That's the motto of KMC. And to start with, we have I would like to tell you that we will be having a series of master class, basically focused for gastrointestinal ultrasonography. and in a subsequent mails. And at the later, once we finish this master class, we would like to have a live or a hands-on training. And maybe we are designing that course. It will take some time, but first we are going to finish off an online program. Without wasting much time, I would like to invite Dr. Amit Pathak for this platform. And I think if people have questions, please do watch this class, and then do post videos, whatever it is, your simplest doubt, and then sir we can take up at the end of this session. Thank you. I think over to you, Dr. Amit, sir.
Hello, everyone, and thank you so much, Dr. Sharan, for this introduction. And I must thank you for planning this whole thing, because after all, it is your brainchild, and obviously Mr. Chen and his team for giving us this wonderful platform. And I think we'll be wonderful together and start something new, because ultrasonography has been really neglected, and it should not have been neglected in India, because it's a third world country and it is the most easily available diagnostic modality tool for anyone who's dealing with the abdomen. And like echocardiography is for cardiology, so ultrasonography of the abdomen is for gastroenterology. And I sincerely feel that more and more gastroenterologists get interested in, because it's a tool which is an extension to their clinical skills. And I think we can partner with radiologists who are dedicated, who dedicate themselves to gastrointestinal imaging, because as time grows and our number of patients increase and our complexities increase and new diseases come up, I think we all have to master art forms. And medicine is an art, it's not a science, pure science. So I think ultrasonography is also an art which I think some radiologists at least should master. And they can partner with gastroenterologists, and gastroenterologists themselves can use the tools, because after all, US is part of gastroenterology, to go more into diagnostics, which obviously will help them. As Dr. Sharon was saying, we have planned this module in such a way that it is practical based. It is will not go into theories. We will not go into too many facts, because that all is available to all of us and we're reading. We'll go into very practical things, very basic things. And I think we'll stick to that pattern of walking on the road and not flying on it. And so with this in mind, let us start with the first presentation. I have two presentations here in today's session. The first tells you very basic facts, standard facts about what is ultrasound and your ultrasound machine. And subsequently, we'll in this next presentation, I'll be discussing of how to approach a patient, and what are the basics of moving a probe on the abdomen of a patient. How do you move a probe? So, and how do you do it? And the subsequent small movie clips will be an extension of presentation number 2. So, if with the permission of the chair and Mr. Chen, I'll start with the first presentation.
Yes, sir.
Yes. The first presentation actually is, as I said, is basically on ultrasonography only. And I love this photograph because I'm sitting with Dr. Christopher Dietrich, and I have found him to be actually one of the best ultrasonographers I've ever met in my life. And he's a gastroenterologist. He does magic with holding a probe in his hands. And it's always a pleasure to interact with him whenever he's in India. So this, as I had said, this is an introduction of transabdominal diagnostic ultrasonography. We will not go, we'll be touching, as you will see subsequently in further sessions, we'll be touching EUS wherever it is essential, focusing on transabdominal and attaching it and linking it to EUS wherever we feel that that will help. But our focus here is basically abdominal ultrasonography and how it helps us in gastroenterology. As an introduction, obviously the first slide, very basic. What is ultrasound? So ultrasound, as we all know, is high frequency sound, which actually our ears cannot hear, and bats use it, and we are using it for many years now for creating images of the abdomen or heart or vessels or wherever it is possible to understand the pathology and diagnostics of that place, of that organ. Now, in ultrasound machine, there is a probe. I'll show you the probes, and I think all of you must have seen, because ultrasound has such an old modality now. When we started in 1991, it was a relatively new modality, but now it's an old modality. So ultrasound probe actually is like a bat. You know, your bat sends ultrasound and then receives the ultrasound with his ears and interprets and creates an image in its brain. Exactly that is what the ultrasound machine does. The transducer is your bat in your hand. It sends the ultrasound, receives the ultrasound, and then the machine interprets the image that comes in to create an image, which you interpret with your eyes. And so an ultrasound becomes literally your third eye. With the two eyes you are seeing, but this third eye is going where your other two eyes cannot go and creating images, which with these eyes you are interpreting. So ultrasound transducer is your third eye. As I had said, the echo is interpreted by the machine, and the machine has a logger, has software which creates an image. This image, which is created is in the forms of various shades of gray, as we'll discuss subsequently. And these small pixels, like exactly like in your black and white television, you know, you had these small pixels and your black and white computer screens, which we had. The image is created by ultrasonography. Our focus mainly is on black and white ultrasonography, so I'm not taking up color Doppler here, but maybe later part we take usage of color Doppler in gastrointestinal ultrasonography, but that will be a different session. I'm focusing primarily on basic black and white ultrasonography, which we use 95% of the times or maybe more. Now, what are the advantages of diagnostic ultrasound, and especially in a country, third world country like ours, where a lot of patients will not have the financial support system to go in for multiple CT scans, go in for multiple MRIs. But yes, ultrasound is manageable. That comes within our economic zone. And this is not just for India, but most of the third world and even large parts of West. Ultrasound actually is one of the low costing modalities which gives tremendous results compared to the financial input that goes into it. And it's an excellent tool for the clinician, because it's in the hands of the clinician. You know, the clinician or the person who's doing ultrasound does not need a third person or fourth person to do anything or interpret it for you. Even in an X-ray or a CT scan, it is a technician who will do the imaging, and then it will come to the radiologist or the gastroenterologist for interpretation. Whereas ultrasound is an image, is a tool where you are sitting there and it is in your hands. There's no third person in between, no moderator. You, the patient, and the machine. That's all is there. So it is one of the best modalities. It reduces the factors, improbabilities, and other factors which come in when someone else is doing an investigation and it comes to you maybe after a few hours for interpretation. Or the patient comes with someone else's interpretation and puts it in your hand. So there are a lot of variables there, but here the variables are reduced tremendously. Second biggest advantage is it is a real-time investigation. It is done live. And the patient, when you are doing an ultrasonography, is lying next to you, sleeping next to you, or looking at your face, you are looking at his face, you are talking to him, you are interacting. It is exactly what you will do while examining a patient or taking history. He's there, he's giving his history, he's talking to you, you've examined maybe with your hands, and now you have a tool in hand which goes beyond into the body of the patient to look at the things that you were interested in. So it becomes it tremendously increases your scope of assessment of a patient, because it is an extension of your history taking on your physical examination and then ultrasound. So it is amazing for anyone who learns this art of ultrasonography. As I said, it is real time. So when you are doing ultrasound, you are observing the movements of the body, the movement flow of blood, the movement of the liver. Some places, even in bowel, you are seeing the peristalsis happening live in front of your eyes, the diaphragm moving up and down. You know, in certain places, that becomes that is the diagnostic point, which will help you in diagnosis. So this is a massive advantage compared to all other modalities where you've got still pictures, and these still pictures come and then you spend your mind to rack your head and try to see what must have happened. So this is real time in your hand in front of you and while you are talking to the patient. And one of the most important things, it can be repeated ad infinitum any number of times. Ultrasound has zero harmful effects, which has been proven in all these years. And so reinterpretation of patient, you can see the same patient 3 or 4 times in a day for 2 minutes, 3 minutes for follow-up if you've done a procedure. It is amazing because the patient is comfortable, you are comfortable, it takes no time. Shifting the patient, he lies down, you see, and the patient goes. So not too much of a paraphernalia like in a CT scan, not too much of a movement. It is real time, live in your hands, and that's the amazing beauty of ultrasound. Now some disadvantages, which obviously every modality will have. It is 100% operator dependent, and that is my experience of the past 26 or 27 years since I've been actively doing ultrasonography. And that becomes a disadvantage for a clinician who is a third interpreter. He has to read the report. So it is operator dependent. Second is, it is basically shadow play. It is not real images. Modern CT scans, modern MRIs create nearly anatomical images of the organs that they are seeing. My ultrasound doesn't do that. It creates an image which is not a true anatomical image. Even inside the organ, the things that you see are not exactly as you would see if you do an anatomical section. And it takes a very long time to master. Its learning graph is very slow. US learning graph is probably the slowest. But yes, abdominal ultrasound is nearly as slow as US. It takes years of experience because you have to master hundreds and hundreds of images through years. And then when suddenly you see an image, your brain automatically puts it and matches it with the image in there, which is there in your brain and comes out with the interpretation. So it's a slow modality to learn. That I accept as a pure ultrasonographer. Now, we had discussed this aspect that it is basically not color, but B mode scanning that we'll be discussing. B mode is the primary mode display scanning method. B mode literally stands for brightness modulation, and in short, in very simple terms, it is how bright a particular pixel is. And you can see the shades of gray down there, from complete white to complete black and all shades of gray. And these create an ultrasound image. So that's why it's called B mode scanning, B scan. And how does an ultrasound create images? This we'll be taking in detail subsequently when we'll be discussing liver, because in liver we'll get all the permutation combinations which will help us understand this idea. But in short, how this white and black spectrum is created. One is actually waterborne fat air, as you see below. That is simple because water has got a different density. Bone does not allow any ultrasound to pass through. Fat allows nearly all ultrasound, but then again, fat lies in form of small lobules instead of flowing flat like water in the tissues, creating a different set of parameters, and obviously air. The word above it is interface. So interface comes out of these 3 words which have been given below. Interface literally means what is the difference in the density of two things which are adjacent to each other. Now, water and air, if they are abutting each other, suppose, and we know all our organs are literally mostly water, more than 80% water. So we have one side the liver and the other side air. Or another example is a bowel loop. Bowel loop wall is watery, but inside the bowel loop is air. So the interface is maximum from water to air. Because the interface or the density difference is maximum between air and water in a bowel loop, all the ultrasound that enters the loop crosses the thin wall and gets reflected completely. Same thing happens in the lung. In the lung, what is happening is outside the lung, pleura and all, and then the abdominal wall is water, because after all that is tissue, and lung is filled with air mostly. And so this air and the soft tissue that surrounds it, diaphragm, liver, wall of the chest, creates an interface. And as soon as ultrasound penetrates the soft tissue of the chest and touches the margin of the lung, immediately all of it gets reflected. So what is happening is this difference in density is causing complete 100% reflection away of ultrasound, and that is the biggest deficiency of ultrasound. So the biggest disadvantage out of the other three which I discussed earlier is that whenever air comes, ultrasound goes zero, and that is the problem which we have, which is actually only sorted out by a CT scan. So that creates our limitations beyond which ultrasound cannot evolve, because whenever air will come, ultrasound will stop, like obviously bone. Now, there are two types of probes that we normally use by ultrasound. One is a high frequency probe, and anyone who's seen an ultrasound machine, anyone who's done US will know high frequency and low frequency probes. Now, high frequency probes have frequencies up to 30 megahertz commonly, but even up to 20 megahertz sometimes. Low frequencies mostly are from 2.5 megahertz to 5 megahertz. And in low frequency, which is the commonest used frequency, is 3 megahertz. And so basically, what is the difference? The difference is very important here. Whenever there is a high frequency, the resolution of the image is very good, but the penetration is very less. On the other hand, when you are using low frequency ultrasound, resolution is not as good, but yes, penetration is complete. So herein comes the dichotomy of EUS and transabdominal ultrasound. Transabdominal, because you have to penetrate the whole abdominal wall from the anterior to the posterior abdominal wall. So use low frequencies. But then again, because you are using low frequencies, the image resolution is not as good. Whereas in EUS, or when I do a soft tissue probe, ultra high frequency linear ultrasounds, probes which I use for transabdominal, what you are using is very high frequency. So less penetration. So whatever you are touching, you are seeing it beautifully, but you are not able to penetrate maybe beyond 5 centimeters. They say 5 centimeters, beyond 5 centimeters, even for US imaging is not very good. That is the depth that you can penetrate. But with this 5 centimeter, you will see amazingly good, which you will never see with the low frequency ultrasound. As we proceed into disease and organs, you'll understand what I was discussing here. So the simple logarithm, high frequency, greater resolution, lower frequency, greater depth. This is the basic rule of ultrasound. This is actually a simple ultrasound screen, transabdominal ultrasound screen with date, time, patient name. Frequency is depicted here down on the left of your screen down there. Type of probe is written there. And the dots that are you see are the distances from the surface. That is the distance from the surface. This is a color Doppler image, which we'll take up maybe in the last parts of the session. And this actually helps us, easiest is to differentiate between artery and vein whenever we are in confusion while going through a simple transabdominal ultrasound. Now, this is one part of ultrasonography which is actually literally untouched, and it creates so much confusion in reports. So this I'll clarify with this simple slide. Ultrasonography uses 3 basic terms. The first is echogenicity, second is echotexture, and third is echopattern. Now people mix it within these. So I'll give you the simple algorithm, how it works. Echogenicity is the degree of whiteness. So it can either be hyperechoic or echogenic. That means very white, that is hyper, or echogenic is white. Hypoechoic or echopoor, that is less white, more towards the blackish side. And anechoic, when there are no echoes at all, which is completely black, as you see in the gallbladder or a cyst, that is anechoic. Echotexture, on the other hand, is like the texture of cloth, khadi and silk. That is the texture. So anything that you see, either it is homogeneous or non-homogeneous. It cannot be anything else. And nature gives all organs as homogeneous. So all organs are created homogeneous by nature. Any place you see them to be non-homogeneous, you have to immediately get in mind that this area is diseased. That is the rule of echotexture built by nature. Now, echopattern is this echogenicity and echotexture compiled together. So if we say that the mass has an altered echotexture or non-homogeneous ecotexture, it means it has a variable ecogenicity and has a variable ecotexture. Now, in the next slide, I'll try to make these points clearer. Now, on the left is completely white. Ecotexture is smoothest, that is paper. In between is gauze of two different same ecogenicity. They are both white and nearly similar white. So their ecogenicity is nearly same, but you'll see that the texture is non-homogeneous of the gauze which is above, and the gauze down below has a homogeneous texture. So even though the ecogenicity may be the same, the texture may vary, as you can see in this slide. And obviously on the right, the ecogenicity also varies, and you have a homogeneous and non-homogeneous ecotexture in something which is very hypoechoic, nearly black. So this is the concept of ecogenicity and ecotexture, which we use not just for transabdominal ultrasound reporting, but also US reporting. And I think this is basic fact helps us tremendously in giving the right interpretation in a report as well as coming to a diagnosis. Now, using these terminologies, we come to defining or describing a lesion in an ultrasound report. And I'll tell you, this is very important and interesting because this description also brings you to a relative diagnosis. I'll take the example of a lymph node only. Now, location. So where the lymph node is located. Similarly, it would be a mass. Where the mass is located, numbers. If there is a single mass in liver or there are multiple masses. Similarly, if there is a single node, solitary node in the mediastinum or there are multiple nodes. Then come the margins. Whether the lymph node has well-defined margins or whether the margins are, the lymph nodes are matted, ill-defined or matted or confluencing. Similarly, a mass, whether the mass has well-defined, clearly demarcated margins or whether the margins of the mass are poorly defined and it is merging within the soft tissue that it is part of. Then comes the shape, whether the lymph node is rounded, whether the lymph node is elongated. Similarly with the mass, whether the mass is well-defined, rounded, or whether the mass that you are seeing is having a variable shape. Then the eco pattern, as we had discussed. What is the ecotexture and ecogenicity of the mass? Next point is calcification and liquefaction. Whether it has calcification, liquefaction, then the size, and obviously in the case of masses and sometimes even in lymph nodes, because massive lymph nodes can push the pancreas, push a gallbladder, whether it is having a mass effect. Now, before going to the next slide, I'll just use this paradigm to come and define a lymph node. Suppose there is lymph node which is multiple, there are multiple lymph nodes, well defined, shape is rounded, eco pattern is hypoechoic and ecogenicity is hypoechoic and ecotexture is homogeneous. There is no calcification or liquefaction. The size is above 1 centimeter. Your interpretation on US as well as transabdominal ultrasonography is malignant lymph node. On the other hand, you have a lymph node, again, same location, multiple or solitary. Multiple, we'll take multiple. Margins are ill-defined and some of the lymph nodes are coalescing and merging with each other, matted. Their shapes are elongated and sometimes irregular. Eco pattern, both ecotexture and ecogenicity is non-homogeneous, means nearly soft tissue. There calcification, liquefaction, even if we remove calcification or liquefaction as a criteria, our diagnosis first, even before doing a FNAC, would be a tubercular lymph node. So when you follow this pattern, it's not just that your report looks wonderful, amazing, and the person sees it, knows that this man has looked at everything clearly, but also it helps you come to a diagnosis without doing an FNAC. Now, this is an ultrasound equipment machine, and I've got 2 of them here, and both my machines which I'm using, and we actually have 5 of them, but these are 2 basic. This is a basic model, which is a more of a earlier portable. Now we don't do portable ultrasounds, or a smaller model, and then the subsequent later model. But the basic pattern remains the same. And what you see, first look, it looks like the console, how you open a cockpit in a plane and you look at and you think how the pilots must be operating that. It's so complex. But don't worry, this is not so complex. It's as simple as that. You have obviously the measurements on one side, the trackball in the center, the knobs for distance, color, depth on the right, zooms are here, freeze on one side, dual frequency on the other. You can see enter, and you can see the keyboard. On the left top, you have patient name, how to write. So this is what you use. Rest of it is actually more of paraphernalia and used for very specific cases and very small number of patients. This is what you will be using. But on one thing which I'll be discussing here is on your right above, which is the TGC curve. Now, what is the TGC curve? I'll take in the because this presentation is ending. The last part will be TGC curve. This is the other machine equipment. You see, it is nearly the same, except that from knobs and from older televisions, we've come to newer televisions. So it's something like that. It's just that new technology and new things, but basic structure remains the same. Now, this is a TGC curve. TGC curve, there's something very simple about it. You can imagine that an ultrasound goes into the tissue from the surface. So that is the upper part, it enters. It penetrates down to the lowest part and comes back. So what is happening is all that ultrasound which is entering just from the surface and coming back, because from every point within the organ, ultrasound is being reflected back. Nearly all the ultrasound is reflected back because it did not have to penetrate and lose its energy while going through the organ. Whereas deep, where the deep is written, and the lowermost part of the ultrasound beam, when it is penetrating, a lot of its energy is only lost because it has passed through the tissue all this distance. So when it comes back to the transducer, the ultrasound beams which have gone through the tissue and come back will be of having lesser intensity, or if I can use the term, whereas those which have just gone in and come back are having the maximum intensity. It's like an athlete who's close to the finish line. He runs immediately and reaches the transducer finish line, whereas the one who's completely behind has to run a longer distance and he's more tired. So what we do is what this will do is it will create a very bad image. The portions which are deep in the tissue will become dark black because ultrasound intensity coming from there is less, whereas on the surface they'll be whiter. So what you do is you have this TGC curve. So in this, the upper knobs you turn towards the darker side and the lower knobs you turn towards the whiter side and make the whole image symmetrical. You make the deeper parts whiter and the superficial parts less white. And so that the image, even though ultrasound intensity coming in from surface and deep is different, the image is smooth and similar. So this is a TGC curve which I have turned the other way around, and you can see the difference. The lower part of the TGC curve I have actually pushed towards the maximum side and the upper side to the lower side. So you can see the deeper part of the image is completely white and the upper part has got nearly black. And when I turn the TGC curve other way around, turning the upper knobs towards the whiter side and lower knobs to the blacker side, the upper side of the image is white and lower side is black. So ideally, this is the curvature. This is an S-shaped curvature. If you keep an S-shaped curvature of this TGC curve, instead of in straight line, you turn it S-shaped, this image will become completely smooth. So this was the first part of the presentation. And Dr. Shiran, over to you, please, before I go to the next presentation.
Yeah, thank you, sir. It was a very nice and brief presentation on the basic of ultrasonography. I think as a physician or a clinician, I think it was very simple. So we could understand your terminologies. I think the point you highlighted is the terminology should be very simple. Hyperechoic, hypoechoic or anechoic, then the echo pattern. Then something about the machines we should know. As a gastroenterologist, I think we all should learn something about the machine before we operate EUS. And baseline terminology, like you rightly said, terminologies are very, very important because once we report it, I think that makes a big difference how you report a lesion. And you made it very simple about the surface pattern and the texture. If it is the nature has made our organ uniformity. So I think that's a wonderful sentence you told. I think that's I think for my postgraduates to understand that whenever they see some altered echo pattern or surface texture, I think they should think that this is abnormal. So I think we'll quickly go to the second one, sir, before starting the videos. So you can start your second presentation. And once we finish that, we'll take up some questions, then we go for the videos.
Right. Yeah. So once we've understood some basic facts of what is ultrasound and what is the basics of machine, now it is time to go approach a patient. Now we have a patient, and how do you approach it? How do you do an ultrasound? Because actually no one teaches how you do an ultrasound. Everyone is told this machine is there, patient there, that's the probe, that's the machine, you start. And everyone, actually literally that happens, and everyone starts doing it. And it takes time for, and everyone creates his own protocols and systems and does it all his life. So we have tried to make it more scientific, more professional, actually, if I can use that word. So as I had said initially, when we approach a patient, we are, even if I'm a radiologist, I'm actually a clinician, because after all, I did my clinical medicine and surgery and everything during my course, and I should not forget it. And that actually should support me while coming to a diagnosis. But for a clinician, after all, ultrasound is an addition to his clinical skills. So you conduct a procedure, you do a simultaneous clinical assessment of the patient, because the patient is just next to you, and you confirm the diagnosis. So I have actually put this slide from a radiologist perspective, but even a clinician can use it if he is going first hand with the ultrasound with the patient. In clinician medicine, you do take history, you do a clinical examination, you have a provisional diagnosis, and then you use diagnostic tools, blood investigations, X-ray, and whatever, to come to confirm your diagnosis, because they say that you would already have made a diagnosis, you've done a proper clinical examination. Whereas in when you are doing through ultrasound, I invariably tend to go blind, because if you take too much history, that actually your interpretation is already there, and then you are biased. So you do an examination, you obviously do a simultaneous clinical assessment, and then if you have come to a diagnosis, you discuss with the patient, talk to him, take his history, and confirm your diagnosis. And it all depends on the clinicians or whoever are using ultrasound, which protocol they want to use, because ultrasound actually is adding to what you've already done. Holding a probe is simple, like you hold a pen. This is how you hold a probe, nothing else. Actually, I've got the slide because I've seen people not holding the probe in the correct way, and I think this is the best and simplest way to do it. There's always a knob on every probe which tells you which direction the image is, and this knob and direction I'll discuss in subsequently in this slide. And this knob is most important. So because the probe can be attached either way, and sometimes if you attach the other way around, the whole image reverts. So basically, whenever you go to an ultrasound machine, first you hold a probe, hold it like a pen, and first thing that you, before seeing the screen, you see where this knob is to know what is the orientation of the probe. There's the high frequency probe, which we obviously will be discussing when we're doing clinical cases and clinical assessment. How do you come to a patient? How to approach a patient? Thanks to this Cape Town University image, I think I searched the net, and this was the only one available, which actually showed that you have to always approach the patient from the right. And that is what you do with ultrasound. You are approaching the patient from the right. And because you are approaching the patient from the right, like you do for an examination, the whole image is planned, as you'll see when in the later presentation, by this approach of looking at a patient. So when you're looking at the patient is on your right hand, and you are on his left or her left. So when you put a probe, as you will see when I'll be doing the videos, probe is actually like a knife. It cuts straight in a straight line. So what is happening is and it's a two-dimensional image. It is not a three-dimensional image. So whenever you create an image on the ultrasound screen, if it is on the long axis, that is sagittal axis, you always had the cranial side on your left and the caudal side on your right. So if the straight line is there and you are imaging, suppose you are imaging the left lobes in a straight line, so your heart will be on your left and the pancreas will be on your right. So that is the basic axis in the sagittal scan. And in a transverse scan, the right of the patient will be on your left and your left will be on the right. This I'll show you in the later scan also, but what is happening is, why this? When you are seeing the patient and you are approaching the patient from the patient's right hand, you will see the patient's left hand is on your right, towards your right hand, and patient's right hand is towards the left hand. This is exactly how you've created the image on the ultrasound, and the patient's cranial side, the brain side, is towards away from you, and on the ultrasound it is on the right. And this you can, if people have got confused with what I have said, I'll put a CT image, and we've grown up seeing CT images, and exactly this is the protocol followed on a CT scan. The liver is on your left, the stomach and the spleen is on your right. Why? Because when you are looking at the patient from your axis, the liver of the patient is always on your left and the spleen of the patient is always on the right. This is the protocol followed by CT scans, and it is best when I'm doing a transverse section of the abdomen to follow this protocol on ultrasound, because this will match up with the mental image of the patient as soon as you see him, which is there in your brain. If you see a CT scan, with the CT scan, with an MR, with an MR, so it matches with everything. If you use the opposite protocol on ultrasound, actually it is not the true protocol, because it is not matching up with your brain image of the patient. If you are seeing the patient from, when you are seeing him, you are seeing his liver towards you and your spleen away from you. That is actually how you do it with ultrasound also. And when you will see subsequently, you will understand what I meant when I'll be showing you the images. Now, when you approach a patient and examine, there should be a fixed protocol. Whatever the patient may be having pain on the left, but the protocol, if you decide to go in a circle, follow that protocol precisely in every patient, wherever the pain may be. You will not miss. I have seen, and sadly so, that a lot of people do ultrasound like they drive on Indian roads. This is how it is. Whereas they should be doing this. Whatever happens, you follow a pattern, a system, and organization. It helps you in many ways. First of all, you will see every organ precisely as it should be seen. You will not miss a disease because you've gone in a precise way. And thirdly, your measurements will be precise and accurate. This is what I had been discussing, and this is what comes through this slide, and this will be showing you in the subsequent videos. There are two sections, as we discussed, a long section and a transfer section in simple language. And when you are approaching the patient, you are approaching the patient from the right of the patient. Your probe can either move in the long axis or the transverse axis. Now, in the long axis, if the probe is moving, you fix it in the long axis with obviously the heart towards your left and the lower part of the abdomen towards your right. And then you slide, like you see the lines on this image, to one side and the other side in the long axis. Similarly, in the transverse axis, when you put it in the transverse axis, what you do now is go up and down. So you have only two primary movements, right and left, superior and inferior. And that's how you take sections of the abdomen by an ultrasound. And this is the primary movement of the ultrasound image. And as you can see, if you are holding a probe, you turn the probe 90 degrees, you get long section. You turn the probe 90 degrees, reverse that axis, and you get the long axis. And that is how you are moving the probe. And you are doing all the interpretation. Every organ should be seen first in long axis and then in transverse axis. But there are two places where the problem comes in. First is liver. Because liver, as you can see, there are the ribs. Ribs will hamper assessment. So in this case, what you have to do best is, you will have to turn the probe slightly obliquely and put it between the ribs. But instead of moving straight up and down, you move it perpendicular to the ribs, as can be seen in this arrow. This image actually typifies it. If you put straight on the, so these arrows are pointing to the ribs shadows, which are darkening parts of the image. So the image is not complete. So what you do is, you put the probe slightly obliquely between the ribs and then move from intercostal space to intercostal space to intercostal space, up, down, to see the whole liver. Next point is POTA. And I'll tell you a very simple way to look at CBD and POTA. This is the simplest on earth and rarely changes. You same probe which you've done oblique in the axis of the ribs, you bring it to the midpoint of the right subcostal margin. The probe should point towards the anterior superior iliac spine of the left side. And you slightly move the probe on both directions. Porta hepatis lies at that point. As simple as that. You just turn the patient, and you'll see in the videos, you go to the midcostal margin, put the axis of the probe towards the anterior superior iliac spine of the opposite side, and the porta will be there with the CBD and the portal vein. One place which every ultrasound examination you'll see. The only variable here is the gallbladder, because gallbladder is a very naughty child. It can lie everywhere in all possible positions. So gallbladder, you ultimately have to master the skill of searching for the gallbladder and then coming to the diagnosis of the gallbladder disease. Now, this is the porta image, standard porta image, and the gallbladder, obviously. In this case, it was a nice gallbladder. It was lying where we wanted it to be. Same problem comes in with spleen, because spleen again is behind ribs. So what you do again, you slightly make the probe oblique, put it in the intercostal space between two ribs, and then move superiorly, inferiorly, pointing towards the anterior superior iliac spine of the left side. Lot of of the right side. Lot of people find it difficult to see identify the spleen. It is easy. You'll see in the video subsequently. But again, if you put it between the ribs of the left side and move slightly up and down in the mid or posterior axillary line, the axis of the probe towards the anterior superior iliac spine of the right side, you'll get the rib. You'll get the spleen, and the next video will help you in this. What I'll be, you'll see it practically happening. What I'm showing here. So then again, as a spleen with the rib shadow, but you can see most of it because that's how we did it. It's an enlarged spleen, by the way. And thank you so much for my presentations. And I think let's proceed for the slides. And I request Dr. Sharon to introduce the next session, please.
Thank you, sir. It was, I think, as usual, wonderful. You made it so simple. So it's very interesting, like, as from a clinician point of view, actually, you made it so simple. It looks very easy now, this white and black. But if you, without, like you said, it has to be a very organized manner. So whenever we have an ultrasound in our department. So when earlier, we were never systematic. So when we use, it's always black and white, we get confused. But once we followed a protocol or a system, then it makes us very easy. So the point to our postgraduates and young guys who wants to learn is, this is not very difficult. And like you said, it is going to be a very complementary for all the physicians. Now, mainly gastroenterology, I'm telling, because we are dealing with ultrasonography of GIT tract, we call it hepatobiliary ultrasound. So the point is, it has to be a very systematic way. Start from basics, then you can see the disease, and then, always have a good colleague or a radiologist so that, you can have a complement in your clinical cases. So I think the next session is actually the very interesting one, which I found it because I've searched Google, because when I started learning, I searched a lot of materials in the YouTube, but nowhere it has been so simplified. I think once you go through this, I think you will definitely agree with my suggestion that sir has made a very simple videos to scan, or this is a basic. I think we have 5 or 6 small videos.
7 videos, small ones.
Small 7 videos. I think, yeah, just everyone will get an orientation, and I think mainly for our postgraduates, so who wants to initiate in their clinic or who wants to initiate in their department. This is really an eye opener. Please do be, very attentive, and please watch these videos. I think we'll go to the next video session, sir. Please, live to you.
Hello everyone, and now I'll be discussing how to start with an ultrasound, how to hold a probe, how to do basic ultrasonography. So the first thing is how to hold a probe. So fact remains that how do you hold a pen? It's as simple as that. So you hold a pen like this. Most of us hold it like this. Similarly, when we have a probe, we hold it like this, like you hold a pen. There is a marker in the probe which decides whether you are looking upwards or downwards. Now, what does that mean? That means that ultrasound is basically a two-dimensional imaging. So either it images in the long section or the transverse section. It actually, this probe sends ultrasound beams which cut the patient like this or like this. And so if you have long section, you go in the midline. If you have transverse sections, you go transversely, like we do with the CT scan. Important point is that this decision, whether you go transversely or vertically, is fixed in your brain because you always have this marker in your mind. So this marker keeps the position of the probe precise in your hands. Now, most of the organs can be viewed in the long axis or the transverse axis. The problem comes in two places. Hello everyone. Now, how do you approach a patient? Actually, traditional medicine is, we are taught that whenever we approach a patient, we approach from the right side of the patient. So when we approach the patient from the right side, the head and cranial side is on our left hand and his feet are on our right hand. This is for a view, one view. Now if we turn in the other axis, we will see the right side of the patient is towards our left and the left side of the patient is towards our right. Now this exact orientation I keep because everyone has a different protocol. I prefer to keep on my ultrasound screen because my ultrasound screen image then precisely mimics the position of the patient as I am seeing or approaching the patient. Now how do you approach a patient? This is the right lobe of liver. The problem with right lobe of liver is that you have the ribs like this. So it helps. Ribs is no problem. You always keep the probe over the ribs like this and the rib shadows will come. Or you can keep it between the ribs and move it slightly up and down to see various parts of the lobe. Preferably, you move the right lobe, first section you take between the ribs like this, straight. And then you keep it between the ribs and go up and down, up and down, up and down. And the third place, because the ribs are causing this problem here, is you keep it below the ribs and see upwards, cranially. This is see the CBT, that is the primary issue. So first is how to see the porta hepatis. Porta hepatis actually is a very easy to visualize. You see the lower inferior posterior margin, you keep your probe in the midline of the lower posterior margin and point it towards the anterior superior iliac spine of the opposite side. This is the axis of the porta hepatis. Invariably you put it here, you go to porta hepatis, and because the liver most of the cases is not enlarged, so what you do is you turn the patient, you see the lower posterior margin, put it in the center blindly, pointing it towards the anterior superior iliac spine, and you have the porta hepatis. CBT actually comes from the porta, as I had said, anterior superior iliac spine and the posterior margin middle, and then it anatomically we imagine CBT as like this. No, it is not so. The CBT goes down and then tilts like this. It turns, hooks on the lower medial aspect of the duodenum. So once you have to see the CBT, you travel down, come to the head, use the head and then rotate the probe completely to see the lower CBT. That is how you see the lower CBT. The head of pancreas lies here. Anatomically, images we have is pancreas is lying transversely across the abdomen, but it is not so. The tail of the pancreas reaches the splenic hilum. So it goes slightly superior. So what you do is, To keep the probe in the midline over the pancreas, use the left lobe or the stomach as a window. See the pancreas and tilt it slightly with the probe tilted upwards on the left side so that it goes towards the splenic tail, towards the spleen. And this is how you see the pancreas. Now when we have seen the pancreas, now we'll see how we see the CBD. Lips on the spleen. So the lips are here. And the spleen. Now liver is easy because liver is a bigger organ. But spleen becomes difficult because spleen is a smaller organ. So for spleen you have to put it between the ribs. So you put here, see the direction of the ribs, put it between the ribs and then get the section of the spleen. So for spleen you invariably have to turn around, see where it is seen best and keep it at the right place to get the best section of the spleen. Machine, basically the most important part of the machine is the freeze, the trackball, the distance measuring, but technically it is the TGC curve, which is this TGC curve. And how the TGC curve operates, we'll be discussing in the presentation that is will be coming up. So this is the TGC curve. Every ultrasound machine has a TGC curve. When the image of the patient comes, as we had discussed, the left of the patient is towards our right and the right of the patient is towards the left of the screen, because it's the long axis. In the transverse axis, the patient's right is on the left and the patient's left is on the right. So that means liver is on my left and the spleen is on my right, because I am seeing the other way around. It is actually the precise depiction as is seen on a CT scan. Machine basically the
I think all the videos are done, no?
Yeah.
Sir, can you connect to Amit, sir?
Yes,
Dr. Amit Pathak. So we
Yes.
are done with all videos, right?
Yeah.
Yep. Okay.
These are the okay, fine. I think that's it, no, sir.
Yeah.
You have any more?
Yeah, no, that was actually the basic part, because actually the videos were just an addition to what had been discussed in the presentation. And one of the important things is, while approaching a patient, the cranial of the patient is on our left. So the same protocol we follow while doing the ultrasound screen, on the ultrasound screen, and the liver of the patient is also on our left. So the same protocol while doing a transfer section. And then how to basically look at the basic organs. And this is what is important for GIT. So I'm not going to bowel because that's a different issue, but basically liver, left lobe, right lobe, porta, pancreas, spleen. If you can go through this circle and see all these organs, I think most of the things are covered, because they are just additions to these major organs on that ultrasound interprets.
Sure, sir. So, Jan, do you have any questions on the chat box actually?
yeah, sir, I have not seen any question in the chat box, but I request the audience to, place the question in the chat box, or the audience can, if you permit, that audience can unmute themselves one by one and ask the question directly to the speaker or the moderator.
Okay, that also, I think that's the fair presentation we had today, basics. We just wanted to initiate this concept. We didn't want to go to the deceased or show the bile duct or liver, which is already on the internet. So our aim is mainly for our postgraduate, that how do you, when you start doing basics of ultrasound, a terminology you should know, and then how do you scan? Like sir said, you should not be in a hurry to directly go to the organ of interest. You should go in a very systematic way, the horizontal or a longitudinal axis. First start with the liver. It's a very, for a gastroenterologist, day-to-day practice. So important to start with liver. then porta apparatus, and then bile duct. So sometimes we can trace the bile duct up to the ampoule if we can do very nicely in a very slim person. Then next fashion is our interstitial pancreas and spleen. So I would like to tell my postgraduate at least start doing this in each and every cases in your practice. Many at least when they have inpatient and we have a machine right in our department. And once you start doing it, you will try to learn it more and more. And in the subsequent class, what's our plan is to focus on each organ. Now we have told you about basics. The next master class is basically on an organ, and we will show you the image, how it, both with the hand movements as well as the image, how do you trace whatever the interest for a clinician, like mainly the liver, the texture, and the bile duct. So that's the next master class. And in case if you have any questions, I think sir will be happy to take that questions.
Sir, could you check your chat box also? Sometimes the audience can send the personal message to you. So I request both of you check your chat box also. Is there any question?
Sir, we have a comment from Dr. Satish Midas. He's saying it's a lovely and crisp presentation, also beneficial to the clinician.
Yeah.
Thank you.
And there is one question actually from one of the phones. Can you use the term heterogeneous ecotexture? Yes, actually, basically, people have multiple terms which they can use. I personally have been using homogeneous and non-homogeneous, but yes, heterogeneous actually means non-homogeneous. So this is a term which can be used because I think linguistically it won't be long, and I think it's a term that you can use. Like anechoic and ecopoor, now they mean the same thing, so we are using both terms. So I think heterogeneous ecotexture is a very well accepted term, and because I have not used it, so it was not on my slide.
Sir, I think there's one question who asked how to diagnose early CLD.
Yes. CLD we'll be taking up when we'll be discussing liver, but then the most important thing comes in CLD is ecotexture, and even more than ecogenicity, because fatty infiltration to cirrhosis is known, but we all know that a lot of patients would not have gone into on ultrasound, would not show fatty changes, but will show frank cirrhosis, which is actually the more common type of cirrhosis diagnosed by ultrasound. And the term again, which will help us diagnosis, is ecotexture. The simple people say is lobulated margins and other things, but what happens in the liver is a normal liver, as I had said, God has created it homogeneous. And when the next session we'll take liver, I'll show you a normal homogeneous liver. And when cirrhosis occurred, it breaks down its pattern and makes it non-homogeneous. So when you will see both the images together, you'll immediately know this is cirrhotic. The term which describes as well as the diagnosis cirrhosis is heterogeneous or non-homogeneous.
So the next question is is TGC adjustment necessary in newer machines and US, or is it automatically adjusted?
Actually, yes, this is a very good question, and I like to answer it because I was thinking of it. Till 5 years ago, the machines were like cars with gears, and now we are having cars without gears. So that has happened to ultrasound machines also. So a lot of these gears which we had in the older machines, we had a lot of knobs. They have actually become obsolete because these new machines automatically create the best image possible from the algorithms that are built to them. And that is what is happening. TGC I simply took because it is a prominent marker on every ultrasound machine, and everyone who's going in to start an ultrasound should know what is the TGC curve. But as frankly speaking, we are using it very less in the modern machines, and even today, even now, though I have a very habit of turning the TGC curve because it's been an old habit for 25 years, but still I don't need to touch it much at the moment.
So there's another question, simple way to measure liver and spleen size. Maybe we'll be taking up few subsequently, but maybe you can just shortly answer this question.
Yes, actually there is a debate, and I'm on one side of the debate on the measurement. I'll give you a reason. This is what is, and this I read in a book called Felsen years back when I was reading chest. He said, what is the right size of a nose? Or what is the right size of lips? So when he said in gross anatomy, we do not have the right size of organs which we see, what is the right size of an eye? How can we have fixed parameters for organs which are within the body? We cannot. It's the same thing actually. So, and especially in case of liver, it becomes more problematic because sometimes the left lobe is genetically small and there is a compensatory larger right lobe. And sometimes there is a genetically small right lobe and compensatory larger left lobe. And if you are measuring only the right lobe, again you may be wrong because the be compensatory enlargement of left lobe and not of the right lobe in early cirrhosis. So I am not a very good proposer for measurements, but yes, it helps in one way if the same patient is there, not in multiple patients. And you want to follow a patient of hepatitis and see whether he's responding to treatment or not. So in that case, obviously you can take the right measurement of liver, which we'll be discussing in the next presentation, and then follow that measurement to see whether the liver is regressing in size or not. And the spleen, actually this problem is lesser because spleen has a single organ which has not got multiple lobes, so its measurements are there. But when I'll be discussing spleen, I'll give you a simpler method of assessing splenomegaly. You put the probe and you know this is splenomegaly or not without measuring it, and you'll get a very good rough idea whether it is mild, moderate, severe. I use the term mild, moderate, and severe in place of splenomegaly, though obviously we'll discuss the measurement system also in spleen, which is different from the liver.
Yeah. Dr. Girish had actually complimented and also said the sonography is done by technicians and pictures are uploaded to computer. Usually radiologist reports by seeing the images from the computer. What's your comment?
This is the American system of doing ultrasonography, not the European system of doing ultrasonography. Okay. In the American system, why this actually ultrasonography has not grown compared to CT and MRI and other modalities in the past is because the maximum funding for research, obviously we all know, goes in US universities, and in US traditionally ultrasound was always done by technicians. Radiologists would not do ultrasound. They were not taught. They were taught how to interpret ultrasound images like they do for CT or MR, where the technician does it and they interpret it. Same rule was being followed by ultrasound. Whereas in Europe, especially in Germany and Northern Europe and these areas, the radiologists, gastroenterologists, and clinicians were themselves doing ultrasound. So their approach was completely the opposite of what the American approach was. And this American approach is one big reason why ultrasound is not a very loved modality, even in the third world, where our circumstances are very different compared to the US system of medical management. So I feel the Europeans are doing better, and I think it is a modality which is just an extension of your own body in hand. And I said, as in the earlier presentation, it is your third eye. Just think of it as a third eye, which is beyond your two eyes, and you will see it as in a very different light. Ultrasound as such, it's a very good modality if thought in that perspective.
Yeah, there's another comment from Dr. Anil. He said, good basic learning session, thanking us. Then Dr. Srikanth has asked us, how much do we learn about the gain for physicians?
Pardon, sir? How much do we?
From physicians, how much do you learn about gain?
Gain means...
yeah, the depth and the gain.
Actually, as I had discussed, answered the question earlier, in today's equipment, the image is nearly smooth. You can go very fast and the machine does most of the job. But yes, it helps because you have to continuously make things brighter and darker as per the patient requirements. And you have to change the depth continuously a lot of times because the patient size varies. And sometimes you have to have a disease which is much deeper and sometimes it's superficial. So because I said ultrasound, the best thing, it is live. It is front of your eyes. With your tools, you are moving up and down, going in and out, and the patient in front of you. It's a live examination. And then these basic tools help. My point while showing the screen was that most of the things are not used in a regular examination. They are for specific purposes. But when you look at the machine, it looks very, fearsome. So there's no fear in it. It's just that basic tools of, as you said, depth, gain, and dual imaging, focus, and maybe zoom that are basically used.
Dr. Girish asked what artifacts to be aware of and how to better enhance images.
Okay. There is a very good presentation of Dr. Malay Sharma on that, and we have discussed it earlier. And we've been working on this artifacts and other things of ultrasound and making images best. Again, in that, I'll start with the basic point that modern machines, 8 years, 10 years back, we had those presentations, and I also presented those. And we had a lot of these points which we used to take. In the machine which I showed today that we have, the latest machine which we have acquired, actually very less of that is needed. We just start the sound immediately because the quality of machines is very good and their software is so good. But still, I'll like to assert that other than obviously air, which is the biggest enemy of ultrasound, there are artifacts of ultrasound are there, but they are not as big a problem as say in MRI. You know, so ultrasound has artifacts. The modern images machines have removed most of them, and sometimes the artifacts are helpful. Like when we'll take gallbladder, you would understand when there are cholesterol deposits in the gallbladder, there's an artifact which comes down behind the cholesterol deposit, which is in the which is a comet tail sign, and that helps us to diagnose cholesterol deposit in the wall of gallbladder. So whatever artifacts other than air, whatever it is causing, and maybe bone, we can't penetrate, is a mixed bag. And as subsequently we'll go into sessions, we'll see images of real patients and diseases, and wherever the artifacts are there, I'll be discussing those and what they mean for us. And there's one artifact, there are multiple rings come in and other things come in with fatty patients. These artifacts are more, but the modern machines are able to eliminate most of them.
Okay. I think the next couple of questions are based on artifact and actual abnormalities, I think, which we are going to take up in subsequent master class.
Yes, yes.
Abscesses or hepatic metastasis also we will be showing, and we'll be telling about those things. So liver, there'll be individual one class on that.
Yes.
And what is the point where we keep the focus point for transabdominal ultrasonography? Dr.
Yes.
Srikanth Gopi wants to know.
Yes, it's a very important question, because focus also can be moved continuously while doing the examination. Like a TGC curve, we can move it up and down. And focus actually is transabdominal, its role is limited, but EUS, its role is much bigger. Because there's a big difference while using focus in transabdominal and in EUS. Transabdominal, we invariably put the focus in the center, and we use the TGC curve to increase the brightness of the deeper parts and reduce the brightness of the superficial parts to create a homogeneous image. So transabdominal, it is focus. And if at all, suppose we want to focus on transabdominal, what we do is use the zoom function. You go into the organ, you zoom it, it becomes big and you can see it. So focus has a limited role in transabdominal imaging, but in US it has a lot of role, because US, suppose you have walls of the layers of the wall of the stomach you have to see, then you may not get those layers in the center of the screen. You may be getting at one part in the outer part or the deeper part. US again is a mobile structure, and your point of interest may be away from the center in US a lot of times. So then focus helps. So focus is much more helpful in US compared to transabdominal ultrasonography.
Okay, I think that's the question. My question is, what's your message to our young colleagues or postgraduates, that how do they get interest and how do they start doing this?
I think they should think of it as an amazing tool. And in our setting, where we literally do most of the diagnosis followed by plain ultrasound, if we mix it with the US and ultrasound, through ultrasound we go into US. And a lot of clinicians who are come as residents and who are with us, and we've known them, who are interested in US, ultrasound, used to use it a lot of times for their routine management. It is a very quick tool. If a patient comes and you suspect gallstones, you put a probe, you steer stones there, it's done. And then subsequently you immediately plan what to do. If the same patient has to go for a CT scan, he'll come back to you after a few hours, and the report will not be there in the hand, and you are talking to the clinician asking what it is. Similarly, in pancreatitis, if you when we'll discuss pancreatitis, we have a ultrasound protocol for pancreatitis. You put the probe and you are suspecting pancreatitis, and it is amazingly good. at interpreting acute pancreatitis and even directing you as to what may happen, what you have to plan immediately, because sometimes the best time to do a CT is not for diagnosis but to see what are the complications evolving after 6 or 7 days, as we do in our case. Because this patient comes and he says, I have money only for 1 CT scan. Now you cannot have 3 CT scans for him in a week. So ultrasound fills up all that gap. So it is a major filler when it comes not just for diagnosis but for follow-up, where you have to use CT scan or MRI judiciously. Another place is, I'll give you a simple example. Closing it, I'll give you a simple example because a lot of you will be doing ERCPs. Ultrasound is the best and simplest modality to diagnose ERCP perforation and even to come to a conclusion as to what will be this morbidity, mortality status of the patient and how you should follow this patient up in the next 5 days. We'll take a session on complications and ERCP, management of perforations, bowel perforation, ERCP perforation, US perforation, and then you will see, because it is real time, it is in your department, it just needs a movement of a probe, and the patient is wheeled in with it on his trolley. He's there next to the machine. You just defreeze, put the probe, and then you can see what is there inside. So it is quick, smart, fast, and it actually directs you what to do next. So instead of thinking too much, it helps you immediate. It makes your protocol and follow-ups very fast and quick. So ultrasound is an amazing modality, and I think GIT, it can do wonders. And I think that is our purpose here. This was just a basic orientation as to how to use a probe, move a probe, and how to look at a patient, how to approach a patient. But maybe when we go for subsequently, you will get that point of view also. And that's what Dr. Shirin was also saying.
Yeah. Thank you, sir. Thank you. I think if no more questions, and I think Mr. Chayan, you have anything to say?
Yeah.
We have, sir.
Yes, sir. We are going for a formal closing. So wish you all the best for the next, masterclass series. So Mahesh, we go for a formal closing. I just share my screen.
Yes.
You can start, Mahesh.
Good evening, all. On behalf of Zydus, I, Mahesh Marathe, consider this as an honor to propose a vote of thanks and acknowledge the contribution of those who really work hard to make this event Masterclass Series 1 on basics of gastrointestinal sonography a grand success. We are immensely thankful to our course moderator, Dr. Shriram Shetty, for conceptualizing the entire event. Our heartfelt thanks to our expert speaker, Dr. Amit Pathak, for taking out time from his busy schedule to be with us today for this event. Sirs, indeed, it has been our privilege to have you all for this event. And thank you for enlightening us with your knowledge, experience, and expertise in understanding the basics of gastrointestinal sonography. Last but not the least, a big thank you to all of you participating clinicians without whom the event would not have been possible. It goes without saying that we will continue to rely on your affection and support now and hereafter. Good night and see you again soon. Thank you. Stay safe.